Hi, all. Welcome to today's session. We are going to deal with the management of common clinical conditions in the primary care. In this session, we'll focus on few diseases also like hypertension, diabetes, respiratory illness, and gastrointestinal illness and musculoskeletal complaints and all. So, let's begin with today's session. We'll have an overview. In primary care, we manage both the acute and chronic diseases. So today, we'll follow an evidence-based approach. For each condition, we'll discuss the typical clinical presentations, essential investigations you have to do and you must not miss, and then the management also divided into OPD and IPD approaches. Uh, so you have to remember primary care, it prevents the complications by early detection and consistent follow-up. So like we are not making the condition worse, leading to a severe complication. So initial stages itself, in the acute stages itself, we are going to handle the condition. First disease we are going to discuss is diabetes. So diabetes are often, like we'll see the presentation, how it is presented. It is presents with the polyuria, polydipsia, weight loss, fatigue and all. Though there are many other asymptomatic things, and in anyone with risk factors or any symptoms, measure the fasting glucose, plasma glucose, and consider HbA1c. You can do the test FPBS, PPBS, HbA1c, RBS in systematic, or if there is any risk factors or any symptoms present, you can do this test. For acute symptoms, measure the RBS for quick decision making. Or for baseline test, you can do HbA1c, fasting glucose, urine routine, that is albumin, creatinine also you can do, and LFT lipid profile, and also you can do a foot and retinal screening as indicated, and screening for any kind of neuropathy using the monofilament should be done in the OPD. So this is what things you have to be doing in the this is the presentation and the investigations you will be doing to the diabetes patient. How you will deal the condition in OPD versus IPD? In OPD management, always start with a structured lifestyle counseling, diet, that is carbohydrate quality, plate food method, and exercise, weight loss targets. First line of drug choice is metformin unless it is contraindicated. Teach the SMBG monitoring basics and plan the follow-up every 4 to 6 weeks initially. Then escalate the therapy based on the HbA1c target and any comorbidities. And you can add SGLT2 inhibitor or a DPP4 inhibitor as per the guidelines and patient factors. And always screen and treat the hypertension and dyslipidemia accordingly. So this is how we'll be doing in the OPD management. In IPD management, in severe cases, admit the patient for any DKA or HHS with severe hyperglycemia or sepsis. You have to admit the patient. Start the protocolized IV insulin regimens, correct the fluids and electrolytes. Notably potassium electrolytes. Monitor the glucose level hourly until it is stable, and plan the this treatment protocol and the discharge education and the follow-up. So this is how you'll be doing the dealing with the patient who is diabetic in the OPD versus IPD. Next comes the hypertension. Hypertension presentation. Hypertension is usually silent, and patients may report a headache or dizziness, but most are asymptomatic. Confirm the diagnosis with the multiple BP readings, preferably a home or ambulatory BP when available. Baseline investigations you have to do is which include ECG, renal function test, electrolyte, urine albumin creatinine ratio, fasting glucose, and lipid profile to assess the cardiovascular risk. And also look for a secondary causes if onset is young, resistant, or with features suggestive of endocrine renal disease. So this is how will be the presentation investigations you will be doing. And next, how you'll be dealing this in the OPD versus IPD. In OPD management centers on lifestyle modification like salt restriction, weight reduction, physical activity, moderation of alcohol intake, and smoking cessation. And pharmacological therapy you can do is choose the first line agents based on the comorbidities, like ACE inhibitors for diabetic or CKD patient, CCBs for certain populations, thiazide diuretics where indicated. Titrate drugs to achieve the BP targets and schedule the follow up for medication and the side effects, any kind of side effects. So this is how we'll be doing dealing the patient in the OPD. Versus the IPD management, hypertensive emergencies which require IV antihypertensives, for example, IV labetalol, nitroprusside in selected cases. You have to continuously monitor the patient and treatment of organ specific complication, for example, stroke protocol, acute heart failure management and all. Then transition to oral therapy and arrange early output patient follow. So that's how we'll be dealing with the hypertension patient. Next comes the respiratory illness. So respiratory illness, common respiratory presentations which include wheeze, shortness of breath, and exercise intolerance. In OPD, use the spirometry to distinguish the asthma, that is a reversible obstruction, from COPD. COPD is like a fixed obstruction, and measure the peak respiratory flow for monitoring. Then chest x-ray is indicated if infection, persistent symptoms, or a suspicion of alternative pathology. Assess triggers, smoking, occupational exposure, allergens, and recent infection. So these are the things you have to be knowing about the asthma of the things. So next thing will be, so this is and you also have to assess the triggers and severity of the patient. Next, how you can deal this condition in the OPD versus IPD management. OPD management for asthma or COPD, like start with bronchodilators, SABA for quick relief and controller therapy, ICS for asthma, LABA with LAMA for COPD, depending on symptoms and exacerbation history. And also you have to teach the inhaler technique and spacer use, create an action plan for exacerbations, and review the vaccinations also. Then you can also do a pulmonary rehab referral for the COPD wherever available. Next is the IPD management. So how you can deal the IPD management? IPD severe exacerbations, it require oxygen to maintain target saturations, nebulized bronchodilators, systemic corticosteroids, and in some cases IV antibiotics if infection is suspected. Monitor with ABG when needed, and consider non-invasive ventilation or ICU referral for any kind of respiratory failure. Next comes the GI disorders, or that is dyspepsia or GERD. So we'll discuss the presentation investigation. Patient with dyspepsia report epigastric pain, heartburn, acid regurgitation, bloating, or early satiety. And first line of investigations depends on the age and the red flags, like H. pylori testing, urea breath test, or stool antigen in appropriate patients. LFTs if hepatobiliary disease suspected, and abdominal USG if RUQ pain or palpable mass is present. Then endoscopy is indicated for alarm features like weight loss, GI bleeding, dysphagia, or persistent symptoms despite the therapy. So this is what are the presentations of GI disorders in the dyspepsia and GERD. Next comes the OPD versus the IPD management of GID. So OPD management, first thing you can do is start a PPI trial for typical reflex symptoms, counsel on the lifestyle changes, that is weight reduction, head elevated, sleep, and avoid trigger foods. And if H. pylori is positive, provide the eradication regimen or test for cure when appropriate. For dyspepsia without red flags, consider the functional disorder management with reassurance and review of the NICAD uses. So this is how you will be dealing with the dealing of gastrointestinal illness in the OPD basis. And when it comes to the IPD management, so for suspected upper GI bleed, stabilize the patient, stabilize the airway, breathing, circulation. IV fluids is given, blood transfusion is needed, IV PPI, and arrange the urgent endoscopy. So for severe infections or cholangitis, admit for IV antibiotics and possible intervention. So that is how you'll be doing in the IPD management. Next comes the musculoskeletal, that is low back pain. Low back pain is very common. Most cases are mechanical and improve with the conservative care. Key history is onset, radiation, neurological symptoms, bladder or bowel dysfunctions, and systemic features like fever and weight loss and all things. Then red flags are that require imaging or urgent referral include the progressive neurological deficits, saddle anesthesia, history of cancer, trauma, or suspicion of infection. Then you can also do routine X-rays, which are not required unless the red flags are present. MRI is indicated is when neurological compromise or surgical pathology is suspected. So this is how the presentations will be, and how you can deal with the OPD and IPD management. In OPD, most musculoskeletal complaints respond to the conservative management, analgesia, physiotherapy, and guided exercise, and use targeted investigations only when the red flags exist. For chronic conditions, consider the multidisciplinary care, physiotherapy, occupational therapy, and pain management clinics. So this is how you'll be dealing the patient in the OPD versus the IPD. And IPD neurological, if there is any neurological deficit, IV analgesia, MRI evaluations can be done. So summarize today's session. In primary care, we treat the majority of these conditions effectively with early diagnosis and guideline based OPD management and timely recognition of indications for IPD care. So always document the red flags, set a clear follow-up plans, and use the patient-centered simple treatment plans to improve the condition. And this is how you will be dealing with the patients in the primary care. So our aim is to treat the condition from the OPD basis itself. Like you don't need the condition to be leading to severe cases. So in the OPD itself, you should be able to treat the condition effectively and more prominently in an effective way. So that's it for today. Thank you so much and have a nice day.